So hello and welcome to the third and final Fireside Chat discussing cases in sleep telemedicine. Once again, I'm Barry Fields, and I'm a sleep physician and director of sleep telemedicine at the Atlanta VA Healthcare System. And I am joined once more by an outstanding panel of sleep practitioners from around the country. And together we will be discussing case one in the AASM's Sleep Telemedicine Implementation Guide. So before we go through the case, though, I want to let each panel member once again just briefly introduce themselves to you all. So we will start with Dr. Marty Martin.
Hello, I'm Dr. Marty Martin, and I'm a psychologist out of Chicago and in a clinical setting as well as in a university setting.
Great. Thanks so much for joining. And we'll move on to, well, Chicago again, Dr. Donskoy.
Hi, I'm Dr. Inessa Donskoy. I'm a pediatric sleep medicine attending at Advocate Children's Hospital.
Great, thank you. And we'll head out west to Phoenix, Dr. Traster.
Hi, I'm Matt Traster. I'm one of the sleep and epilepsy neurologists at Phoenix Children's Hospital at Barrow Neurological Institute.
Great, thank you. And last but not least, Mr. Dennis Kelly.
Hi, I'm Dennis Kelly. I'm an advanced practice provider and nurse practitioner in the sleep clinic at the VA Northeast Ohio Healthcare System
Wonderful.
in Cleveland.
Cleveland, Ohio. All right. Thank you again all for joining me today. So let's get started. Let's get right to this case. So I am going to turn the screen share on so that everyone can follow along with us through the case. So you should see now my opening screen that this is a fireside chat about obstructive sleep apnea. This is case number 1 from the AASM Sleep Telemedicine Implementation Guide, both the original version 1 and now we have an updated version 2 as well. So we're going to go ahead and get started with the case. So Mr. J was a 58-year-old man living in rural North Carolina who was referred for evaluation of possible obstructive sleep apnea, or OSA. He had a history of hypertension, type 2 diabetes mellitus, and increasing weight gain. He was referred for a sleep medicine evaluation by his primary care physician because of increasing daytime somnolence, decreasing energy level, increasing snoring, so much to the point that his snoring was actually disturbing his wife's sleep. Because of the long distance required for travel to the nearest board-certified sleep medicine physician, the patient used his smartphone to connect to a telemedicine platform available through his healthcare system. So let's pause there. So the first question then is for Dr. Marty Martin. So Dr. Martin, what are some ethical considerations that apply to this use of telemedicine?
And there are a number of them that I will enumerate. So the first one that comes to mind is one for safety. So given kind of this excessive daytime sleepiness, it's probably wise that he's not driving actually to have the visit. Now, someone could drive him, but he should not be driving. So I think that's where telemedicine really fits in, because access is one thing, but you also want to make sure that the patient is safe, that they don't harm themselves or harm someone else. So that's the first ethical consideration about safety. The others have to fall upon privacy. So it was mentioned in the cases he's using his smart device to then connect with the platform. So one of the challenges when you use a smart device is you have to be concerned about, is the data encrypted? And then might there be a breach in confidentiality? So I think that when you do the informed consent, you might do the regular informed consent, but you have to really spell out unique risks and benefits with regard to telemedicine. So there you would have to, in a very kind of easy to understand way, let him know that there's certain risks by using a smart device and that you have certain safety protocols in place in order to prevent that. But when you're doing the informed consent, one of the challenges from an ethical point of view is, does the patient actually understand? Because part of it is about the ethical principle of autonomy. So people have to understand in order to make an autonomous decision. So you want to check it on his health literacy. So does he have an understanding about some of the diagnostic terminology and digital literacy? Does he have an understanding about, the device risks with regard to privacy? The other thing that you want to make sure that you have in place behind the scenes that you wouldn't necessarily discuss with the patient is what's called a business associate agreement. So this kind of relates to HIPAA. And as you know, HIPAA has a legal component, a regulatory component, and an ethical component. So you want to make sure there's a business associate agreement in place if there's 2 or more devices that are connecting to a central platform. The last ethical consideration is this, does this particular patient live in an area that has broadband access? And then also, does the patient have a device that can actually be utilized for telemedicine? And this really goes back to the ethical principle of justice. So those are some of the primary ethical considerations that are important. But I'd really want to impress upon you is safety must come first do no harm. And the second is you're going to have some special provisions with regard to informed consent.
Really interesting to consider all of those elements here. So there's a lot. Thank you for that review. Let's move on to another question, actually. And there we go. So this next one is for me. So the question has come up, what are some important considerations regarding payment, such as insurance parity laws and government payer restrictions? And of course, we all have to recognize that we need to get reimbursed for these sessions, right? We can't have these sessions and lose money on them because then we wouldn't have a clinic. So we have to think about reimbursement. We have to do our homework. So when thinking about reimbursement, think about the different ways that generally we get reimbursed. So there are commercial private insurance companies. There are more of the federal payers, such as Medicare, a state payer such as Medicaid, and then maybe out of pocket. In some models, patients pay out of pocket. So the insurance parity laws apply to the first of those, which is the private insurance companies. So most states now, I think nearly 40 states, require insurance companies to pay the same whether the patient seen via telemedicine or in-person care. In other words, there should be parity between what they pay for patients seen in person or through telemedicine, thus the parity laws. So do your homework, check and make sure that your state has a parity law to ensure that if you charge a private insurance company, you'll actually get reimbursed appropriately for that visit. On a government on the government insurance side, there have been restrictions as well. So the major national insurer, Medicare. So for years, there had been very heavy restrictions on where patients are when the telemedicine care is happening. And even more like what conditions are being treated through telemedicine. Now, through the COVID-19 pandemic, some of those limitations and restrictions have been cut down a bit, but we really don't know where this is going to go permanently. I think more services through telemedicine will be reimbursed, but we can't assume just because we have the technology that we can bill Medicare for care rendered to a patient and that Medicare will actually reimburse us. So that's changing over time. And the Centers for Medicare and Medicaid Services, or CMS, have a great website where you can go and actually see what the reimbursement is at that moment. And then also I want to mention, since it talks about government payer restrictions, think about state governments and think about the states themselves with Medicaid. So there are restrictions. For instance, some states require written consent to be in the patient's chart that the patient will be participating in the telemedicine session, similar to what Dr. Martin raised with his ethical discussion. So if that's not there, you may not get reimbursed by state Medicaid. So do your homework, know your state, know your rules, and I would last say, know your definition. When states say they have parity laws for telemedicine, what do they mean by telemedicine? They may not reimburse you for a telephone call, even though that technically is telemedicine. Usually telemedicine in these terms is referring to real-time audiovisual communication, similarly to what we're doing now if it were live with you all. And so it's sort of clinical video telehealth, CVT. That's usually what states are referring to and what Medicare often refers to. So do your homework about the rules locally, nationally, and with private insurers, and know your definitions. What do they mean by what is telemedicine? All right, enough from me. So,
if I could just,
yeah,
if I
please.
could just quickly add something as well that goes along with Marty's idea. I know that as part of our medical record, we have actually a piece in the note, a little box that you check that states that you've discussed this with the patient and that the patient has given you permission and understands what the risk benefit is. And I think that's important when you're doing this to make sure that you adequately document it. So if a question does come up for reimbursement, you can say, no, we've agreed with the patient and here's our documentation of such.
I love it. Any way that you can make it easier to remind yourself to get the consent and also to just have it in the chart and not miss it in a complete templated way or whatever works is a great tool to have. So thank you for reminding me about that. Very, very important. All right. So let's go back to our case, our patient, Mr. J. So during a telemedicine appointment from his home, a thorough sleep history was elicited by a board-certified sleep physician, and a physical examination was performed through the use of the patient's smartphone camera. So pretty cool stuff going on, but of course it raises some questions about how to do that. So for Dr. Donskoy, what techniques have you found useful to examine patients over telemedicine, especially in your pediatric population?
Yeah, along with all of the rules and limitations that you all, very, very thoroughly listed, I think we have to remember what a privilege it is to be invited into these homes where a patient is so much more comfortable, especially my pediatric patients. And I often remind them that there are no shots that I can give them through the camera today. So people are just more at ease, and that makes gathering a physical exam just that much more easier, even with all of the limitations. Our physical exams are different. The things that we're going to look for and document are going to be different. We're not going to be assessing a heart rate. We're not going to be, feeling for hepatosplenomegaly on the abdominal exam, but there's a lot of observation we can do. And so our templated physical exams are different, but really just as thorough with as many systems. So much can be gathered from just the first conversation, right? A laugh, symmetrical movement of the face, movement of the arms. You've got part of your musculoskeletal there. You've got part of your neurological and psychiatric as well. And because they are more comfortable, right, you can even ask them to do silly things like stick your tongue out at me, right? Or for what we want as sleep medicine providers, right? Can you open your mouth big and wide? Remember, in this case, the patient's on his smartphone. So he can take that phone and move it any which way. It's flexible, right? He can actually aim it at his oropharynx, show us his mallampati, show us if he has tonsils. Probably not because he's an adult, but that's what I care about seeing. And there was actually a really nice, small, but really nice ENT article that came out in JAMA during the pandemic that said that images of the oropharynx that are taken with a smartphone camera are more than half the time acceptable and usable by providers for what they need. So maybe that bar is a little low, but we just need an image we can use. We just need information that we can take a next step with. If the patient was instead on his laptop or a desktop, then we do the exam a little bit differently. Often my patients will have a parent or a caregiver with them, but if they have someone else or they're handy themselves, they can just be reminded where the camera is, which is at the top of their monitor, and they can actually use the backlight of their phone to shine nice and bright. You play around with their angles a little bit and you can get a fairly nice exam as well. If we want things like neck size, we can have them look for a tape measure in their house. If there are certain things that are important for our documentation, you might ask your nursing or scheduling staff to have the patient have ready next to their device or whatever they'll be using for telemedicine so they can help you with that part of their exam. But they're home, they're comfortable, so they want to partner with you to help them get the physical exam that you want.
Great tips. And I have to tell you, I have not seen that article in JAMA, so I want to see it because there are a lot of questions about the utility of a telemedicine-based physical exam and how to do that. So thank you for the tip. I will be looking at that.
Yeah, it's limited, of course, if you want an inner ear exam, but there are commercially available attachments that people can purchase for their smartphones. And then, whereas they won't be able to show you via video, through whatever EMR portal you're using for telemedicine, they can then digitally send those images.
Great.
So there's ways around this too.
Interesting stuff. And I think telemedicine is here. We're going to have to find ways to do this and to know the limitations, which we'll talk about in a little bit, but also finding new ways to perform a physical exam. And it's certainly reasonable to do, as you've said. So interesting stuff. Okay. So I will move on to the next little part of the case here. So based on the results of that physical exam assessment that you heard about, a home sleep apnea test, or HSAT, HSAT, was ordered. So the next question or related questions are for Dr. Traister. How does HSAT ordering work across state lines? How do HSAT ordering rules via telemedicine vary by state?
So it's a great question, Dr. Fields, and I will tell you, it took a lot of work to figure out this one because there's a lot to it, and so I'll try to break it down in ways that are relatable to most of us. So I think there's a few ways to answer the question. It depends a little bit upon how you're coming at it. Like there's this notion of patient-directed care where the patient themselves is initiating this process. There's commercial payers, there's this concept of global billing, and then there's the whole notion of Medicare. Now, the AASM website has a frequently asked questions section, and this shows up on there, and I'll just read to you the response. So it says, who can interpret a home sleep apnea test? What are the requirements for physicians interpreting a home sleep apnea test in a different state than the state where the test was administered? And the official answer from the AASM is that with polysomnography, interpretation requirements for home sleep apnea testing are outlined within insurance policies. For example, many Medicare and private insurance policies require board certification in sleep medicine in order to interpret both polysomnography and home sleep apnea tests. State licensure requirements vary from state to state. However, in most states, it's required that a physician interpreting the test hold a medical license in the state in which the test was administered. In the case of home sleep apnea testing, the physician interpreting the test will typically be required to hold a license in the state where the patient was tested. So while that is a blanket statement, it's not always correct. So for this patient-directed care, as you may recall for a while, and again, what I say here is not an endorsement of any one particular product, but there was one of the tonometry devices, the WatchPat. There's two, WatchPat and Night Owl, but for a while, WatchPat had an Amazon store and you could literally just go on there. That's subsequently gone. However, there's multiple websites. If you just Google order a home sleep apnea test, for example, I got one time from something called CPAP My Way. There's another one called WatchPap. There's just different places, and they're about $200. You can order your own sleep test and it'll be interpreted and it'll go. There are no provider interactions or exams required for those. When you're just paying for it, these rules don't really apply. So that's one way to look at it. The commercial thing is a little bit more vague, but in at least 3 states that I could find, Florida, Alabama, and New Jersey, there's some regulatory issues that can be a little bit more problematic. So in Florida, Alabama, and New Jersey, they require you to have a standalone non-physician practice sleep lab in order to obtain a state license to perform sleep testing. So persons who perform home sleep apnea tests in Florida, for example, have to be licensed as a healthcare clinic unless there's some sort of an exception. And there are some exceptions that may be relevant. For example, if you have a practice that's 100% owned by physicians, you might be exempted from this particular aspect of licensure. In Alabama, for example, all persons who provide sleep test services must be first licensed as a sleep lab. And so there's some tricky things with those states as far as commercial billing, but with commercial billing, it sounds like as long as the interpreting physician is in the same state where the testing was done. You can order the test from any state and get a result. So that's the kind of long and short of it, I think. So let's just say, for instance, I'll try to give you a hypothetical that might help this make a little bit more sense, because I think it's all a little bit confusing if you haven't spent a lot of time reading about it. So let's say we have a hypothetical provider who wants to perform, sleep testing as part of, her or his menu of services. Let's say that provider decides to contract with some sort of a national or a regional home test provider to perform the technical aspects of the test and even the test interpretation for whatever reason. So under this program, the PCP, or excuse me, not the PCP, but the provider would then examine the patient for suspected OSA, and if indicated, order the home sleep test and use the logistics vendor to ship out the device and instruct the patients in its use. The patient would then return that device to the vendor, who would score the test and then send the data to a sleep specialist, presumably in the same state where the test was performed, to interpret the test. Then that vendor would deliver the test results to the doctor that ordered it. And then the provider would bill kind of globally to do this. So that's one way to do it. And when you get into the Medicare stuff, it really depends upon some things that I've heard about. I don't have to deal so much with Medicare because I do pediatrics, but these are things I know about from having been in private practice in the past with adult partners. But there are these various jurisdictions that depend completely upon where you live. And within any given jurisdiction, there are these things called local coverage determinations that kind of dictate how things can be. So when I was reading about this, the strictest jurisdiction is called Jurisdiction H as in Henry, which actually covers Arkansas, Louisiana, Mississippi, Colorado, New Mexico, Oklahoma, and Texas. And so in this particular local coverage determination jurisdiction, all home sleep test providers have to perform a face-to-face education and device application with the patient before the study is performed. So in this particular case, if you're a Medicare patient, you can't just mail them one. The technician who performs the actual test or hooks the test up, if it's one that requires to be hooked up by someone, then they go home and do it. That tech has to be certified in a certain way. The physician has to be qualified by having either a board certification in sleep medicine or a PhD with some specialized training in some of these different things. And then they require in this particular jurisdiction that the testing program be accredited either by one of the accrediting organizations or the American Academy of Sleep Medicine. So for instance, you could have like a joint commission, like, for example, accredit your sleep lab. And then the other caveat to this that I hadn't really thought about, it's the last thing I'll mention, is that if we kind of go back to our doctor who is going to order this and have the outside vendor do it, there's this thing called the Medicare anti-markup rule. So if the provider billed Medicare for this home sleep test on a global basis, the interpreting physician doesn't perform most of her or his physician services at that ordering physician's practice, then that billing provider who ordered it must follow this anti-markup rule, which basically says that they have to identify who it was that interpreted the test, and then that will limit the amount of money that person can be paid for interpreting the test. So it's pretty wild how this very simple question goes into so many different intricate details. So you really got to be careful, because you don't want to get hauled away in handcuffs for doing something like, reading a sleep test. And if you're not careful, you could easily find yourself in a bad way.
Thanks. Yeah, there's more to consider. I work mostly in a VA. I really work all currently in a VA hospital, so I don't think about 90% of that stuff. But the levels of complexity are remarkable, and it shows you again, as we alluded to earlier, you got to do your homework with this stuff. This is not a situation that we want to play around with. We don't want you to be in handcuffs. So be very aware of where you live. Are you in New Mexico or Texas or not? And all of that. But wow, thank you. That was a lot of information and opened my eyes to sort of what's been going on out there. So please be careful with this piece, everyone.
And then Dr. Fields, I'd like to kind of weigh in here, because initially I talked about ethics from the point of view of patients, and this kind of brings up perhaps ethics from the point of view of the provider as well. is just making sure you don't cross certain legal and or ethical boundaries when you're practicing in this way.
Absolutely. I'm going to touch on some more ethical, legal sort of stuff a little bit later as well. So that's a great point to remember. All right, let's continue on with the case here. So the patient did get his HSAT device. However, he was able to. It worked for him. So he got the HSAT device and instructions through the mail several days later, and the test was interpreted by the sleep physician. A sleep technologist was available by phone, at least in this model, to answer any questions about the HSAT procedure. Test results revealed severe OSA with an apnea-hypopnea index, or AHI, of 42 events an hour with periods of significant oxygen desaturation to a nadir of 72%. So I'm going to actually open this next question up for the whole group. So we have a guy with severe obstructive sleep apnea, oxygen desats galore. Are there more complex situations in patients with sleep disordered breathing where telemedicine, in your experience, just is not as effective as in-person care? And I'll kind of stop here and open it up to anyone with a view on this.
So I'll start out and jump in by saying, I think where it's not all that effective is many times in CPAP setups. Now, Dr. Fields and I are aware that in the VA, we act as our own DME. So I have, particularly in Cleveland, 6 respiratory therapists, sleep therapists, who do full-time CPAP education. And many times we will get patients that come in from outside the system that have been serviced, by local DMEs. And because of the change over time of the reimbursement structure, the DMEs, of course, have had to cut back on costs. And usually the place that you cut back on cost is with FTEs and employees. And so we've heard some horror stories about patients saying, well, I got a call from the respiratory therapist, and he or she said, yes, I'm going to send you this CPAP machine. And the CPAP machine comes in the mail in a box. There's a mask, there's tubings, there's a machine. There may be a video spot that the patient can go to look up. But frequently the patients, if they have problems, don't have that kind of person-to-person, one-on-one experience to do that. And I think that's where telemedicine can kind of let us down a bit, that they need that initial education so that they're comfortable using the device, so they can tell whether they're using the device properly or not, and they're getting the most benefit. And that's where I see it, at least from our experience here in Cleveland, that telemedicine doesn't always work the best.
Absolutely. Anyone else?
Yeah, I think that sometimes it's a little tricky to do some parts of the exam, particularly when you're dealing with potentially maybe some like central causes of apnea and things like that. Like you can't always get a good look at how dysmorphic someone may or may not be, or what features or stigmata of neurological disease and stuff. Some of that stuff is trickier to do via the phone or the telemedicine business, but I mean, it can be done, but just not as well. There's certain things, particularly in kids with developmental disabilities, where I think you just got to lay hands on the kid. You get a sense of what their muscle tone is, and get a sense of, gosh, can the bridge of their nose even support a nasal pillow? I mean, I think there's some things you just can't do. I think follow-ups you can pretty much do, but new patient stuff, I really prefer to do that in person.
Any other thoughts from the group, or we'll move on? I think those are all phenomenal points. And no matter how comfortable I am with sleep telemedicine, there are occasionally the patients that come along where I just want to show them a mask. I want to show them what it looks like and try it on them and examine them. Some of my obesity hypoventilation patients, I want to get a sense. It's hard to see on camera whether they have pitting edema in their lower extremities and how they're breathing and what their structure looks like when they're actually breathing. How are they moving air and things like that. That can be hard to assess, but the vast majority of my obstructive sleep apnea and sleep disordered breathing patients, I feel comfortable, especially now after this past year, treating through telemedicine. But we always want to keep in mind that when we need to see patients in person, we can see patients in person, and we just need to ensure that the patients are aware that that's an option, and we just may need to push the in-person button at some point. So all really good points there. All right, so getting toward the end of this case, so the sleep physician reviewed results of the HSAT with the patient via telemedicine, their telemedicine portal, and copies of the sleep study were sent to his primary care provider, as well as the durable medical equipment company, the DME, local DME company, along with an order for an auto titrating positive airway pressure machine, or I have it on the slide as an APAP machine. So this is actually a neat question because it touches on several of the points we made earlier. So what is the Stark law and how does it apply to sleep apnea related DME? So this has come up a little bit already. So what is the Stark law? Well, technically, the Stark law does not exist. The Stark law is just another name for, I wrote this down, in fact, the Federal Ethics in Patient Referrals Act from 1989, and it's referred to commonly as the Stark Law. So the idea is this: if you own a sleep center and you decide to dispense durable medical equipment or DME from the sleep center, there could be a conflict of interest where some providers will prescribe certain types of devices, theoretically, because they know that they will get more reimbursement for that. They're selling devices from their own practice. They may have partial ownership or full ownership of a durable medical equipment company. And so since they have a financial stake in that, it's kind of questionable and not really fair. So the Stark law applies to federal reimbursement. So what it says is, what this piece of the Stark law says is that if you want to provide patients with DME from your practice and you stand to gain from that financially, we're not going to reimburse you for that. We will not foot the bill for what you're putting back in your pocket. Now, this does not apply to private insurers. Private insurance companies are not governed by this Stark law, but these are the government payers, specifically Medicare. So if you are in that situation, you need to be aware of your payer base, because if you expect many of your patients to be utilizing your own DME service and they're on Medicare, if they're older and or disabled, you're not going to get reimbursed for that. So it's really useful just to keep that in mind to avoid this, at least perception of a conflict of interest. And this applies to other specialties as well. The Stark law is not just for sleep medicine. Sleep medicine was really in its infancy in 1989. It was mostly for DME and other areas, but it certainly applies to sleep medicine as well. So keep that in mind depending on your practice model, because again, fines and potentially even incarceration can be severe for this. And so the federal government will not reimburse you.
And if I can add, we all know that although third-party payers aren't necessarily restricted by this law, that they pretty much follow along Medicare and Medicaid reimbursement structures. And so most of them have also come along and said, look, if you have this conflict of interest, we're not going to pay you either.
Right, exactly. It's up to them. So be aware. So concluding the case, after starting on APAP, the patient noted prompt improvement in symptoms and was satisfied with therapy. His sleep physician accessed and reviewed adherence and efficacy data remotely and continued to support the patient during regular follow-up via the telemedicine portal. So a couple of questions to discuss regarding the end of this case. They're both related and for Mr. Dennis Kelly. So how do telemedicine providers commonly access patient PAP data, and what are some challenges to obtaining this data?
Well, I think this is interesting because when we look back prior to instituting telemedicine and getting download data from the patients, we often had to schedule the patient for an inpatient visit, or I shouldn't say inpatient, but an outpatient visit, and had them physically bring their PAP machine with them. And then one of our therapists would take out the SD card, download the SD card, print it out, and then give it to the provider or talk to the provider. And so it was quite onerous and hard for the patients to haul things around and be able to do this. But we would get the downloads and be able to go from there. So with the advent of telemedicine, most of the PAP suppliers now have gone to cloud-based services. So for example, I know that Philips Respironics, which we use here at our VA, they have the Care Orchestrator, and it's a cloud-based system. All of the APAP units now have built-in modems to them, and it will automatically upload the data to the cloud. We can access that data from the cloud. And interestingly, there are also patient apps that they can sign up for. So the patient can look at their data, look and see how they're doing, getting some feedback as to what's going on, if there are any problems, and be able to do that. And I know as well, ResMed has their AirView, and they have an app for the patients as well, so they can do that. And so both providers and patients now have access to their PAP data, and it can be very instrumental in reinforcing whether the patient's doing well, or if they're having problems, where the problems are. Frequently, some of the downloads will give some suggestions if they see, for example, a leak or some other problems with it. And those are the benefits of it. And I think that's going to be around for a while. And I know our patients like to be able to access this data and be able to look at it and kind of have some more information as to what's going on. The problem and the downside of it is that where is Wi-Fi access? And so we have the urban-rural divide somewhat in the country. And so sometimes patients have difficulty not having access or not having regular access to Wi-Fi. And so it can be difficult for us, or the cloud actually, to obtain the data from the machine. And sometimes we have this. And so then we're notifying the patient, because our therapist regularly will send a letter out that says, well, we looked at your data and we're seeing that you're not using your machine on a regular basis. Please call us. And frequently the patient sometimes will call and say, I'm using my machine every night, but I don't know why the data is not getting to you. And then when we look, frequently it can be an area where there may not be good Wi-Fi service. But it's good, and I think the patients like it. I think it works for them. I know it works well for us. Patients don't have to bring anything in now. We can regularly check them fairly quickly after they start their data, and that's very useful for adherence data, because we all know that if you look at the data in the first usually 7 to 14 days, that's how the data is going to follow up from there. So if you have the opportunity to follow this data closely, you can help the patient become more adherent, and then better treat their disease over time and avoid the complications that go along with untreated sleep apnea.
Great. And I agree with all of that. That's been our experience as well. And I can remember one patient who did not like the idea of our looking at his data online. And we just turned that function off of his CPAP machine and download traditionally through the SD card mechanism. But that's one patient out of hundreds, probably thousands. So, and most of our veterans, we disclose to them what will be happening. That's a key piece, that your data is going to a secure website and potentially app for us to view. And we reveal that to all of them, but I literally think of one patient who was concerned about it. So we made the alteration for it. But yes, I agree. These are extremely helpful tools. And I think that also leads us toward the last question here, which is for everyone. So are there elements of this case that actually lend themselves better to telemedicine rather than in-person care?
I think the fact that the gentleman was in a rural setting, that he's maybe a little too sleepy to drive. I mean, I think there's some things that really make this one particularly appealing.
Right.
And I would also add beyond that too, if there's going to be follow-up care, then it provides greater access so that we have better continuity of care over time, given the distance.
Absolutely.
I think it has to do, I agree with the idea of particularly patients that may live a distance from a sleep providing area. But I also think, it's the convenience to the patient. many times with home testing and that they're more willing to do that. They're willing to engage with us. And I agree with Dr. Donskoy that, you know, patients, when you're doing telemedicine and they're in the home, they're more comfortable. I think they're more open to ideas and suggestions. They're willing to kind of share with you more things. And that's been my experience with it. And it's been pleasant for both myself as a provider and the patient. And we're starting now to go back to more face-to-face. And I think I'm going to miss some of my telemedicine clinics. It was fun to do, and it was the patients liked it and I liked it. But you know, we'll go back to face-to-face as well.
And I think, you know, they're also comfortable enough to sleep better. You know, the data isn't clear cut necessarily. There is, you know, there are benefits to doing in-lab testing, of course. And, you know, while we think of telemedicine as the way we do the clinic visits, there's a lot that's missed with remote home sleep testing, CO2, other data, being able to troubleshoot. But I think a lot of adults, children, they may be more inclined to sleep better at home. And so now you've gotten essentially all your sleep care, from your initial consult to your test to your download data, all from the comfort of your own home. I think there's a tremendous benefit in that, and feeling like they really own the diagnosis.
I've had experience too where I'll say to the patient, well, we'd like to do a sleep test on you. How do you feel about that? And they're like, well, I don't really know. And then I say, well, how about if we could do a sleep test that we could do for you at home, where you could sleep at home in your own bed? And they'll be like, yeah, I'm okay. I'll do that one. You know, I'll be happy to do that one. So I think we, with home testing and telemedicine idea, really do sometimes get better buy-in from the patients.
All right, so all great points, and some of them are actually mentioned in our learning points. So I'm going to move on to the case summary now and the learning points. So these are some key points for Mr. J's case. So in the practice of sleep medicine, much of the information needed to make clinical decisions can be derived through basic telemedicine-ready tools. Even your smartphone can be useful. Conditions such as OSA can be readily evaluated and managed through telemedicine modalities. Diagnostic studies, which you just heard about, such as polysomnography, HSAT, and actigraphy, are often accessed and interpreted remotely, facilitating accurate diagnoses and effective treatment options. PAP adherence data is routinely reviewed remotely to monitor response to therapy. And then finally, providers should review state regulations and payer requirements prior to initiating a telemedicine evaluation. Do your homework. If nothing else, a takeaway is please do your homework, whether it's reimbursement or Stark Law or any part along the way. And one way to do your homework is to reference this AASM Sleep Telemedicine Implementation Guide that we've taken these last few cases out of for the last 3 fireside chats. And as I said at the beginning of this is our 3rd and final chat. And I want to thank all of you who have tuned in for them and watched them with us and learn more about sleep telemedicine this way. And of course, I want to thank our amazing panel for joining us for these over the past several months, doing these fireside chats. Really interesting stuff. And if our audience, if you all have learned half as much as I have from this, then I think it was a success. And of course, I want to thank the AASM staff as well for providing the infrastructure to making this all happen. So good luck with your sleep telemedicine journey, and we hope this has provided a useful resource to use along the way. Bye-bye.